Hello, Assalamu alaikum. The other topic is today acute myelogenous leukemia. So, acute AML is represented by acute myelogenous leukemia is represented by AML. What is mean by the acute myelogenous leukemia? It is acute give the presentation of that it is immature and having the myeloblast cells in having the myeloblast cells greater than 20% in the bone marrow. The acute will give us this information, while the myelogenous means there are immature myeloid cells. Myelogenous means myelogenous immature myeloid cells. Immature myeloid cells. And the leukemia means the neoplastic proliferation. So here from this information we can derive this definition that what is AML? AML is the neoplastic proliferation of immature myeloid cells, which is characterized by 20% more than myeloblast cells in the bone marrow. Immature myeloid cells in the bone marrow. And the AML mostly occur in the old age, starts from 50 to 60 years. And the clinical presentation which the AML, acute myelogenous leukemia, will give. Here, as there will be abnormality in the white blood cells, so the person will present, there will be the bone marrow failure, because there will be bone failure. The bone marrow, the failure of the bone marrow means that there is the more immature myeloblast cells in the immature myeloid cells in the bone marrow. So there will be pancytopenia, means there will be decrease RBCs, thrombocytes, and also the neutrophils. So the person will present with the pancytopenia. The clinical presentation of number one is the bone marrow failure, and the other is the when the red blood cells reach the organ infiltration, means that the WBCs counts, which are the immature myeloid cells, they rises. So here they will cause the bone marrow failure and also the organ infiltration. If the organ infiltrations occur, what are the organs in which the white blood cells will reach? These are the mostly the lymph nodes, and if they enters the lymph node, then they will cause lymphadenopathy. Number two, they will cause hepatosplenomegaly, and number three, mostly can cause the gums bleeding. The hallmark of the acute myeloid leukemia, in which if you go and find through the morphology of the acute myeloid leukemia, then you should find the MPO. The MPO is the myeloperoxidase enzyme. These are mostly present in the DNA of these cells. As the myeloperoxidase enzymes cannot be identified, so these are formed in the clusters, and these clusters are called our rods. Our rods. What are our rods? Our rods are the crystal aggregates of MPO, and here our rods are presented by the cells as a crystals. This is the myeloid cells, And here our rods are just like these small rods presentation. This is the nucleus and this is the nucleoli, and these are our rod cells. These are rod cells are actually the clusters of the myeloperoxidase. So if the morphology of these are our rod cells, and acute myelogenous leukemia should be presented with myeloperoxidase enzyme, and they were positive, means that they are positive in the R rod. This is the morphology and the hallmark of the AML, acute myeloid leukemia. Here I'm going to present the acute myeloid leukemia from the notes. The most common leukemia of adults, while here the neoplastic accumulation of the immature myeloid cells in the bone marrow. And the clinical presentation is pancytopenia and the infiltration I've explained earlier. And the hallmark is the myeloperoxidase. The myeloperoxidase form the clusters and aggregates to form our rods. And its morphology is when we look for the morphology, the bone marrow will shows 20% greater than the myeloid myeloid cells, and more cytoplasm than the acute lymphoblastic leukemia. The cytoplasm is granular, because here the granulocytes from these myeloblast cells, the granulocytes will produce, and they will be positive in the MPO, our rods. The MPO is absent in the chronic myeloid leukemia or other acute lymphoblastic leukemia. So this point should be noted, that in the acute myeloid leukemia is further subclassified into on the basis of 3 points, that is the cytogenic abnormalities, the lineage of the myeloblast, and the surface markers. Cytogenic abnormalities, we can say that here there may be neutrophilic cells rises, there may be basophilic rises, or there may be eosinophilic rises on the basis of lineage and on surface markers. Okay, so before further going, I would like to uh, explain the FAB classification of AML, uh, which is, I think, the most important in the AML lecture. Okay, the FAB means French American British classification of the AML. Uh, this is the most simplest classification, and you guys learn it throughout within 5 minutes. Is so number first we should start with the MO. These are mostly 8 stages. The M1, MO to M7, and these stages have again some morphologies, and I'm going to start with the M0 or MO. M0 means that before going to write the stages, I would like to present the classification of white blood cells, so that it would be easy for you guys. The blast cells, and then the blast cells, erythroblasts, myeloblast, monoblasts, and megakaryoblast. Monoblast, megakaryoblast, and erythroblast. Okay, so if these are the further divisions of the blast cells. Now, before starting the FAB classification of the AML, I have written these further classifications of the blast cells: the erythroblast, myeloblast, monoblast, and the megakaryoblast. Now let's move to the first stage, that is M0. The M0 means that the blast cells, we should start from the blast. That means the blast cells will lack the definite cytology, means that there is some leukemia present, some cancer is present. Uh, so here the blast cells lack the definite cytology but have the myeloid lineage antigen, means that the blast cells have antigens for their further divisions. They have present, there is not much disturbance caused by the virus or mutation. So the in M0 there will be only lack of definite cytology, but the myeloid lineage antigens are present. So this is the M0. In M2 and M1, sorry, in M1, the blast cells, the myeloblast cells in M1, the M0, the blast cells are lost, while in M1 only the myeloblast cells will be predominant. Myeloblast cells will be predominant, they will be greater, and the myeloblast cells should have present our rods. They are positive in our rods because our rods promyelocytes. uh, so here we should move with the M0, which means that there will be the blast cells will be 0, the red circle, and M0. Blast cells will show that they will lack a definite cytology but have myeloid lineage antigen. In M1, only the myeloblast cells will be predominant and having few our rods. In M2, both the myeloblast cells and promyelocytes are present. They will be present in M2, myeloblast cells with promyelocytes, and our rods are also present because our rods are mostly present in the promyelocytes. So when in M2, promyelocytes and myeloblast cells will be present. In M3, the promyelocytes will be predominant, and here multiple our rods are present. Our rods, I have previously said that our rods are the collections of MPO crystals. These are crystals of collection of MPO, myeloperoxidase enzyme. In M4, only the in M4 only the both the myeloid and the myeloid and the monoblast cells will be present, and this is also called as a myelomonocytic leukemia, M4. And in M5 only the monoblastic in M5 only the monoblastic cells are present, monoblastic leukemia are present. And in M5 a further classification occurs, only the monoblasts are present. If M5A, so only the monoblasts are present. When M5B, so there will be differentiated monocytes and the promonocytes are present. In M6 there will be erythroblasts are present. In M6 erythroblasts are predominant, having more than 50%. Predominant, more than 50% of cells. In M7, MKB are present. The megakaryoblast are predominant in M7. So this is the most better classification of the FAB, AML. AML, acute myeloid leukemia. If in an exam they will mostly ask about M3, what is M3 and how will it morphology of M3. So the M3 is the hypergranular promyelocytes with the multiple our rods, and the M3 here there will be some mutation, and this mutation will be translocation between the chromosome number 15 and 17. I'm going to discuss the promyelocyte in detail because this is important from exam point of view. The acute promyelocytic leukemia, as I've told you in the classification, FAB classification of AML, that acute promyelocytic leukemia is M3, and here it is characterized by the translocation between the chromosome number 15 and 17. And what is the chromosome, which gene is this translocated? That is the RAR gene. Retinoic acid receptor is translocated from chromosome number 17 to 15. The RAR, what is RAR? Retinoic acid disruption. This will lead to block the maturation and promyelocyte accumulates. So if the RAR receptor will be disrupted, they will block the maturation. As a result, the promyelocytes will accumulate and they will give a picture of the leukemia. So this will be called acute promyelocytic leukemia. Abnormal promyelocytes contain many our rod cells, and this will increase the risk of bleeding and disseminated intravascular coagulation. Why this will increase the risk of bleeding? Because our rod cells, they will secrete some chemokines, and these chemokines will activate the coagulation cascade, and as a result bleeding will occur and the platelets activity will be disrupted, so they will cause bleeding and disseminated intravascular coagulation. The treatment is mostly we can give the ultra, which is all trans retinoic acid derived from the vitamin E that binds to the receptor and cause the blast to mature and eventually die. So the blast cells will die. And further we have some classifications. Little bit we will discuss the further classifications of acute myeloid leukemia to end our topic. The further other type of the acute myeloid leukemia is the acute monocytic leukemia and acute megakaryocytic leukemia. Acute monocytic leukemia is the proliferation of monocyte cells like monoblast cells that lack the MPO, and the acute megakaryocytic leukemia, proliferation of the megakaryocytic cells without MPO, and they are mostly associated with the Down syndrome. So these are further names I have already mentioned in the classifications. What causes the acute myeloid leukemia? What is the science behind acute myeloid leukemia to occur? As the acute myeloid leukemia, how acute myeloid leukemia progress? So acute myeloid leukemia arises from the pre-existing dysplasia. The dysplasia that occurs in the bone marrow, and here when the dysplasia occur in the bone marrow, the myeloblast cells will be rises, and myelodysplastic syndrome, the myeloblast cell rises, but it should not be greater than the 20%. It should be less than the 20% cells in the bone marrow. When there is rise in the bone marrow greater than 20%, then they will ultimately leads to acute myeloid leukemia. And the presentation will be the same, as there will be also pancytopenia and also some bleeding and infections will occur. What causes the myeloid dysplastic syndrome to occur? The primary cause is idiopathic, that is, it is unknown. Primary cause of the myelodysplastic syndrome is unknown, when the secondary cause is mostly the radiotherapy, that is alkylating drugs can act on the bone marrow, cause it dysplasia, and when the dysplastic cells reaches above 20%, then they will ultimately leads to acute myeloid leukemia. And this is end of our topic.